afternoon, and thank you everyone for being here today. My name is Sarah Fuchs, and I am a Senior Specialist for the Community Education Department at MDA. We are thrilled to have you join us for day one of the virtual learning series on SMA. This learning event is a part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the Community Education section on mda.org for updates on upcoming events. We are recording today's event and will be posting it to our website for on-demand viewing at a later date. Everyone registered for today's session will receive that information in their email inbox. Please know that all phone lines have been muted, but you can still ask questions. If you use the chat feature, you can type in your questions at any time during the presentation, and we'll be sure to collect those to answer them at the end of each presentation at the Q&A session. I want to be sure to extend a special thanks to our program supporters, argenx, Biogen, Genentech, and Novartis for helping make our programming possible. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments, expanding access to care and clinical trials through the MDA Care Center Network, and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through research, access to care, advocacy, education, recreation, and engagement. Since its inception, MDA has invested more than $1.1 billion in neuromuscular disease research. Our MDA care centers are located at over 150 top medical institutions nationwide, providing care from clinicians who specialize in neuromuscular disease. MDA's advocacy work focuses on support for accelerated approvals and novel research, access to healthcare, accessible air travel, and more. This focus plays a vital role in shaping laws and policies that support the needs of people living with rare neuromuscular diseases. Our community education and recreation programs are designed to connect individuals and families. We are committed to building a nurturing environment where our members can share experiences, triumphs, and challenges. Every year, we offer over 40 educational programs, over 20 summer camps, and dozens of other community activities, both in person and virtually. If you haven't done so already, we invite you to join the MDA community by registering with us. Registering is free, and please see the link in the chat for more information. Now it is my pleasure to introduce today's first speaker, Dr. Matias Lopez-Chacon. Dr. Lopez-Chacon is a pediatric neurologist at Johns Hopkins All-Children's Hospital in St. Petersburg, Florida. He specializes in neuromuscular medicine. He also performs electromyography and nerve conduction studies in children of all ages. He was previously Division Chief of Pediatric Neuromuscular Medicine at Boys Town National Research Hospital in Omaha, Nebraska. Dr. Lopez-Chacon earned his medical degree from Pontificia Universidad Católica del Ecuador, School of Medicine. He completed a pediatric residency at John Stroger Jr. Hospital of Cook County, Illinois. He completed a residency in child neurology at Anne and Robert Laurie Children's Hospital of Chicago. He then completed a pediatric neuromuscular medicine fellowship at Northwestern Memorial Hospital, Anne and Robert Laurie Children's Hospital of Chicago. Dr. Lopez-Chacon, thank you for being here today, and I will now pass the time over to you.
Thank you very much for the introduction. Thank you, everybody, for being here, and thank you from the MDA for organizing this talk today. And we're talking about what is next in gene therapy. I would like to start with just a little bit of kind of objectives for this talk. I'm hopeful that after this talk, we will be able to understand a little bit more how gene therapy works and what happens after dosing it. I hope that you could be up to date on the status of research, clinical trials for SMA gene therapy, and after that, be able to discuss the challenges and ethical considerations for gene therapy in SMA. Just a brief recap, spinal muscular atrophy, it is characterized by the progressive degeneration of the alpha motor neurons in the spinal cord that ultimately would lead to muscle atrophy and therefore weakness. The incidence in the United States is about in 1 to 6,000 live births, perhaps, and the carrier frequency is actually quite high. It's 1 to 25 or 1 to 50 over here, meaning that it is rather a prevalent disease here. It is an autosomal recessive disorder, which means that it needs both of the copies of the gene to be affected in order to cause disease, one from mom, one from dad. And the gene that is the primary cause of this disease is the SMN1 gene. However, the human body has a backup that's safe on the SMN2 gene, which is essentially just an inverted copy of that SMN1. And it's important because there's just one minor difference in that SMN2 gene, which doesn't include this exon 7 out of the 8 exons that normally SMN1 has. And if it doesn't include that exon 7, the majority of the times that SMN2 gene is not going to produce a functional protein, and very few times that exon 7 is actually going to be included and will produce a functional protein. Now, this is important because historically and through natural history studies, we have come to realize that there is an association between the copy numbers of SMN2 and the type of SMA that is present, knowing that if you only have one copy of that SMN2, most likely it's going to be a type 0 SMA, meaning that it will have a prenatal onset. Whereas if there's two copies of SMN2, will the dictate that it should be an SMA type 1 with an age of onset of symptoms before 6 months of life. And mind you, this table is outdated, but it just shows you the importance and the severity of the presentations with the changes on life expectancy as well, depending on the number of copies. And of course, the milestones that the kids should be able to achieve or not with those kids with SMN type 1 being unable to achieve seating. Versus those type 2 SMA would have at least 3 copies of SMN type 2. The age of onset will be a little bit later on in life. They will be able to sit, but will not be able to stand or walk. And those kids with SMA type 3 will have more copies of SMN2, between 3 to 4 copies, and they should be able to sit, and they should be able to stand, and they should be able to walk for the most part, sometimes with assisted devices, whereas those patients who have at least 4 or more copies of SMN2 will have a type 4 SMA, meaning that they will attain all the milestones, and they should be able to remain ambulatory until later adulthood. Now, the care for SMA is a multidisciplinary type of approach. That is the motto of the MDA clinic, where you would see different providers in pulmonology, orthopedic specialists, nutrition, GI, bone health, the neuromuscular specialties, the physical medicine rehabilitation doctor, and of course, nowadays we also like to include mental health as well as part of our mission to see a holistic type of approach for patients with SMA. You have the coordinator, you have families, you have the patient with SMA. We're all working around the same goal. And one big part of that we're going to talk about today is about the medications that we can use. Now, that is the gold standard of care without medications. There are currently, thankfully, 3 FDA-approved medications. 2 of them work on that SMN2 gene versus 1 of them, gene therapy, working on SMN1. The 2 medications that work on the SMN2 gene, what they're trying to do at the end of the day is trying to include this exon 7 that was missing back into the gene, and therefore being able to produce more healthy protein. There's 2 versions of it, you can say. One of them is nusinersen, which is an intrathecal infusion every 4 months, meaning directly to the spinal cord, versus risdiplam or Evrysdi, which is given daily as a little liquid or a pill form currently. And on the other hand, you have gene replacement therapy, which is meant to give you that SMN1 gene back to your body. And remember, you only need one healthy copy of SMN1 gene in order to produce enough protein. Now, imagine that this SMN1 gene, it is short enough that it could be packed into a deliverer. Now, the deliverer that has been chosen for this medication is a viral vector, is the adeno-associated viral vector 9. Imagine that is the anti-husk of a virus, meaning that on the outside, it kind of looks like a virus, but on the inside is empty. There's nothing else there but this gene with certain extra proteins that will make it not attached to your DNA or integrate to your DNA, but live parallel to your DNA, so much as so that it can use the machinery out of your cells in order to produce the protein, but it will never be part of your DNA. That is one of the good features of these viral vectors. Because these viral vectors, they cannot self-replicate, they cannot go haywire in your body, you will have to give millions upon millions upon millions and copies of this viral vector in order to these SMN1 gene to be delivered into the nerves and the muscles. Now, why this ABV9? There's quite a few features of this ABV9. One of them is that it has a lot of affinity for the nervous system and the muscles as well. It can cross the barrier that exists in between, let's say, your peripheral nerves and the cell body of the nerve that lives on your spinal cord, which is actually a very important feature of it. Once it gets into your bloodstream, it gets delivered pretty much everywhere, but has this higher affinity for those tissues. This AAV9, before being trialed for SMA, was trialed multiple different times in multiple numerous studies for different diseases, and therefore it has been studied extensively and showed to be overall safe. And then again, not being able to cause infections in humans by itself. The other good feature is that it can last for a long time within your body. And that is another topic of discussion because once it gets into your cells, it will remain in your cells as long as your cells remain alive in your body. There's, of course, cell turnaround in certain tissues, but we know that neurons, they do not replicate again. So the neurons that you have, that you're born with, are the ones that are going to remain for the rest of your life. So, but the fact that this AAV9 is able to get into those cells would mean that they should stay there for the long term. Because it reaches the spinal cord, is able to get directly to where the cells live. Now, currently FDA approved is for people under 2 years of life, regardless of the type of spinal muscular atrophy, if they meet specific health criteria. Particularly, and the most important one I want to say is that if they have less than 5 copies of the SMN2 gene. It has been proven to be crucial in early stages, meaning that the younger the better. The other limiting factor is that if there's a preterm infant, it should be waited until 37 weeks in order for the kid to receive the medication, because we have to use other type of medications in order to hamper the immune reaction that can happen with this gene therapy. And steroids is the medication of use. Therefore, steroids for chronic term at such a young age can actually impact the brain later on in life. That's why preterm babies should wait at least until they are close to 37 weeks. Somewhat on a case-to-case basis, but that is at least the FDA label for the medication. Now, over time, Zolgensma has proven to be very safe, and it has also proven to have a great amount of efficacy. This is just the latest information regarding the long-term trial for patients with SMA type 1 in the form of the START trial. After these almost 7 to 8 or 10 years of follow-up, there was no reports of severe adverse events, no side effects that has been long-lasting. For those kids that were able to follow up after the 9 years of this cutoff point, 10 of them were able. Initially, 15 were dosed. Currently, they were able to follow 10 of them. 6 of them used a feeding tube, while the other 4 did not. Mind you, this is an extreme difference from natural history on patients with SMA type 1. All of the patients were able to sit without support. 2 of them were able to walk unassisted, and currently 5 of them are able to walk with some assistance. Then again, just to remind the benefits, patients with SMA type 1 historically would have the life expectancy severely affected, averaging between 8 months to 2 years of life. So achieving these results, it is of great magnitude. And these are some patients who were treated after 6 months of life. On the patients who were treated before 6 months of life, the majority of them are able to walk. All of them sit unsupported. None of them need respiratory support. None of them have needed feeding tubes. And needless to say, for those patients who were treated before 6 weeks of life, the results have been even better. The majority of them acquired the milestones as walking within the target time for otherwise healthy patients. And then again, stressing the importance of early treatment in that population. Now, of telangiectasia, it is a bit of a process and requires an experienced team and requires a lot of teamwork from every single part. It should always start with the consultation and diagnosis. Nowadays, thankfully, throughout the United States, newborn screening includes SMA. And once the state recognizes a case of possible SMA, it's sent for confirmatory testing. At the same time, the pediatrician gets notified and the parents get notified, and both of them choose a specialist or a clinic where they can start receiving care for SMA. Of course, ideally should be a pediatric neuromuscular medicine expert or a neurologist who have had a great experience and a lot of experience dealing with or treating patients with SMA. Once that happens, there is a second step confirmatory testing for SMN2 copy number variants. And that is important, as I mentioned before, because nowadays, at least up to today, the consensus status by all the experts across the world is that patients with more than 4 copies, meaning 5 and above, should not present symptoms. Whereas some patients with 4 copies, they could present symptoms in adulthood. However, they could still present symptoms earlier on in life, and therefore it is recommended for patients with 4 copies to receive any type of therapy. It is also important because there's just very few laboratories out there who will be able to confirm the specific number of copies, which then again can create a delay in treatment. Therefore, the expertise of the team that you're working with will probably be very important in choosing the right type of test that will confirm the copy number specifically. Of course, it has to be a thorough evaluation to make sure there's no other comorbidities that will hamper gene therapy, particularly liver disease. Before treatment, every kid should be tested for antibodies against this viral vector. The number is 1 to 50. That's how it's reported. And again, although this virus is not present in the wild and does not cause disease on humans, it is part of or similar enough to this adenovirus. And this adenovirus is rather common. So sometimes the body tends to create this type of all-blanketing type of immunity and can create similar antibodies to AAV9, and they can show up positive. If that were to be the case, we do tend to test again and again and again, because at such a young age, we know that the body has not produced true immunity, so they can go down. However, sometimes there are the cases that the antibodies just remain high, and that makes it a contraindication for gene therapy. As I mentioned before, making sure that the liver is function well, maybe making sure that the kidneys function well, making sure that all the blood lines are in the right numbers, particularly the platelets, and having a thorough cardiac evaluation as well. Then after all of those things have been obtained, the patient has been deemed to be a good candidate for gene therapy, which all of these should ideally happen within the first 3 weeks of life. It comes the insurance approval, which can be a different battle by itself, and it really varies from state to state. There are some states that are much more complicated and then put a lot of more processes for us to battle with. However, then again, it comes the expertise of the team you work with. We do tend to go up to the highest forms of appeals that you can think of, including state fair hearings in order to get these medications approved. So it's a battle, and we need just a lot of time and then a lot of effort to get it going. It is a costly medication, therefore insurances do have an issue with that, and that's why they try to put every single possible complicating factor on books for it. Once it gets approved, then again, depending on your hospital and your insurance, ideally, according to the studies at least, before 6 weeks of life, as those studies have shown to have most benefit. Date of the infusion, 1 day before infusion, should I say, we start the medication. We start steroids in order to decrease the inflammation that can happen secondary to this infusion. And this medication, these steroids, will remain in the body for the first 30 days, and then they will decrease a little bit, which I will talk in the next slides. However, on the day of the infusion, usually they come in the hospital in the morning. It happens in the hospital. The infusion itself lasts about 60 minutes, so it's really nothing grandiose. We usually do place 2 IV lines because it's such an important medication that we don't want anything happening there. Usually it is a very highly trained staff for infusions that have received training from the company, training from the hospital, and all the types of recreation necessary. So they're experts on infusions. So everyone is there for about 60 minutes. Post-treatment monitoring follow-up. It's a little bit also depending on the institution, but there's no required hospital stay after that. Some practices do it, some of them don't, but it is required at least 4 hours after the infusion to monitor for any possible side effect in the form of an allergic reaction, you might say. They have not happened in all the studies or in all the commercial patients. However, we know that we need to keep looking at those things. Then I have a little chart afterwards that is going to explain a little bit of the post infusion monitoring, that it is rather intensive for the first 2 to 3 months. Now, as I said, infusion, 60 minutes. Prior to infusion, we start steroids at a rather low dose, but those steroids are meant to be in that exact same amount for the first 30 days. At the end of those 30 days, one can decrease them over another month, and then we monitor without steroids for yet another month. We monitor different things. This is a good chart, just shows you the things that you should expect during those first 3 months after infusion. And that is essentially weekly lab work for the first 2 months, and then every week for the third month. And those weekly lab work that will happen within the first 2 months is the liver function testing, and the platelet count, on the other hand, will happen monthly for the first month, weekly for the first month, and then every other week for the second month, and then same for the third month. Now, we know that the gene therapy can carry some side effects, and the main side effects are inflammation towards the liver. That's why you check those labs every week for the first 2 months, every other week on the third month. It can also cause thrombocytopenia, decrease on your platelet count. That's why you check it weekly for the first month, every other week for the second and third month. And it can cause this thrombocytic microangiopathy, which is a specific type of immune reaction towards your blood cells that can cause decrease in platelets, but also cause them to clog in the liver and in the kidney, and cause inflammation over there. And it has also shown to increase troponin I, which is a cardiac enzyme. Now, this part of the label was included because on the preclinical trials on mice, it showed that increased troponin I, they were not sure about the significance of it, but they had to include it within the follow-up human trials. And it shows that during those 2 to 3 months, there could be an elevation of troponin I, which is an enzyme of the heart. However, all those patients during clinical trials and post-market evaluations have not had any heart problems. We still do check it, and if we think it is rather elevated higher than what it has shown on the clinical trials, we do tend to have a cardiologist waiting on it, perhaps get an echo, make sure that the heart is all right. And we have done these things, and it's always been fine. But it's just for you to know that we do check on that, and that is, it carries on from a preclinical state more than things that we have seen after that. There's this other little, not little, but kind of big important part that there's the viral vector shedding. So it's essentially once you have getting the medication, your body has metabolized it and is getting rid of this viral capsid. This viral capsid actually can go into your feces, into your urine, into your body waste, essentially. Therefore, during that time, it's better to carry on with good amount of hygiene, in the sense of, imagine that you will be back on the COVID times and you cannot, the little kid cannot share spoons or straws or water. They have to have their very own thing. Perhaps keeping them about 2 to 3 weeks of school, just because although this cannot cause infection, we don't know how this viral vector will react with other people. So although it's not infectious, we don't want to cause dissemination of this viral vector to the regular population in order to create mass immunity. So during that time, hand washing, proper disposal of diapers, try to keep them at home, trying to not be a lot of people. Then again, it's not so much for the kids, but rather not to spread the immunity towards this viral vector that can in turn just becomes mass immunity eventually. Now, that is the current label for Zolgensma. Less than 2 years, proven to be very beneficial. The earlier, the better. Proven to be overall safe. None of the patients who have received Zolgensma until now has required long-term hospitalizations or long-term side effects. The liver enzyme changes that have been seen on patients who have received SMA have been transient. All of them have gone back to normality. They can persist a little bit past the 3 months, but they don't cause any liver damage by itself. Therefore, the label still remains to just check up to 3 months of life, not really past that. Long-term trials have shown that all those enzymes have normalized, for sure, 100% of the times over the years. But after that, there was this big question: why would it be given intravenous? And one of the things is that the specificity of the viral vector, they did different type of studies, and they included different types of ages and a little bit of weight, but they didn't include people older than 5 years of life or 21 kilos, above 21 kilos. And what happens is that because we had to give these millions upon millions of copies, the older, the higher weight the person is, you might require higher doses. And at some point, the body just can't metabolize that all too well, or the immune reaction just becomes too aggressive for the body to handle. So that was one of the major things that the medical community had to keep working on. So the next thing for gene therapy was a different type of delivery for the medication. In this case, intrathecal, directly to the spinal cord. Now, in the spinal cord, you have fluid-filled space where the spinal fluid is at, and the motor neurons are just living in there. The body of the neurons are living there. So you can say that it's more a direct type of delivery that will go directly to the cells that are affected. So therefore, it will let you give less dose and create same and or better effect, if that makes any sense. Now, this intrathecal formulation, it is still on clinical trial, you might say. The company has already sent to the FDA to expand the label, and I'll explain you a little bit more about the different type of trials that have been going within this same subset. So the first one is called STRONG trial, which is the study of administration of intrathecal Zolgensma in spinal muscular atrophy. The goal of this study was to evaluate the safety and tolerability of Zolgensma in infants and children with 3 copies of SMN2 that, very important, have been able to sit, but have never been able to walk. The patients were included for this study were between 6 months and 5 years of life. Important, they have this negative gene testing for this SMN2 gene modifier variant, this one over here. This is a positive modifier, meaning that if you have this modifier, this variant in your SMN2, it will make you produce more of that SMN2. Therefore, the phenotype, the presentation of the disease would be less severe. So it was important for this study to obtain the most classic, the most common type of presentation for SMA. Another part of the inclusion criteria was to have symptoms before 12 months of life. Then it go a little bit consistent with SMN type 2. Patients were able to sit independently, not standing or walking independently, and the sitting independently was described as being able to keep themselves with the head up for at least 10 seconds without the use of arms or changing the body position to keep that sitting position. They have quite a few exclusion criteria. And I think it's important just to kind of go over a little bit of these things, because that will give you a little bit of the insight as to what the company has sent for approval by the FDA as part of the expanded label. And one of them is if there has been any shunting procedure, would be a contraindication in that study. Severe contractures that would be evaluated by the physical therapist that would prevent them from keep good analysis of the motor scores that they need to get in order to assess for efficacy. Severe scoliosis as part of this study was considered more than 50 degrees on the spinal curvature. And if they have had surgery, for this specific one, would have to be at least 1 year either before or after the trial. And this is just trial purposes, so not necessarily a contraindication in real life, but just for trial purposes. One of the contraindications that perhaps would carry on would be the use of invasive ventilatory support, meaning tracheotomy with positive pressure ventilation, or pulse oximetry less than 95% at a screening when the patient is awake, which has been considered as one of the main changes from gene therapy, as we saw early on those patients who received their regular intervention. The use of non-invasive ventilatory support for more than 12, for equal or greater than 12 hours a day over 2 weeks prior to dosing. Same thing. This is part of the main goals of gene therapy in general. So it perhaps will carry on afterwards. And this one it was an interesting one. It was the medical necessity for a gastric tube. And I think that was just referring to patients who have been losing weight and are at risk of keep losing weight. However, it's not a contraindication, or it would not have been a contraindication in that study if they already had a gastrostomy tube, G tube. Because in this type of study, you would still remain with the careful use of steroids the day before, first 30 days, and then decrease over the next 28 days. Of course, they cannot have any allergies to prednisone or steroids in general. Of course, not have, if they have antibody titers elevated against AAV9, they will not be part of the study, which that will be across the board. And of course, having overall normal baselines in terms of liver function and the blood cell lines. Now, the study ended up including 23 patients. They were enrolled in 3 different type of groups: low, medium, and high dose. And they were kind of divided into 2 cohorts: one of younger patients, meaning 6 months, 24 months, and the one for older patients between 24 and 60 months. And after 12 months of treatment, the older group on the medium dose, it demonstrated a significant improvement on the Hammersmith score, which is the gold standard for motor assessments on SMA. Comparison with the natural history patient with SMA, that would mean that at least 3-point difference. And in this study, it showed that there was a good amount of change that was clinically meaningful change. So we know that it works. All children, part of this study was also to assess the safety, right? So all children had 1 or more treatment emergent adverse events, side effects. However, the most frequent events were upper respiratory tract infections, fever, cough, vomiting, and constipation. One of them had elevated enzymes that were liver enzymes that were considered serious. However, it resolved with the steroid treatment just for longer and higher doses. And none of the patients required invasive ventilatory support, and no deaths were reported. So safe, and it works. So therefore, they kept going with the different arms of this intrathecal study. The second one was the safety and efficacy of the intrathecal Zolgensma in patients with type 2 SMA. The name of the study was called the STEER study. In this one, was looking specifically for treatment-naive patients, meaning patients who had never received disease-modifying therapy in the form of nusinersen, risdiplam, or IV gene therapy. The group population for this study included patients that were older than 2 years of life and younger than 18 years of life. They were able to sit independently, but then again, never attained the ability to walk independently. Part of the exclusion criteria included common things: elevated ABV9 titers, liver dysfunction, required invasive ventilation or non-invasive ventilation. This one was just a little bit more precise, into more than 6 hours on a 24-hour period, or non-invasive ventilations for more than 12 hours in a 24-hour period, the more classic one. In this one, they also decreased a little bit the angle of the scoliosis to more than 40 degrees on a sitting position, not much of a change. And also, of course, severe contractures that will hamper the ability to obtain good scores or reliable scores on the motor assessments. Now, clinical significant sensory abnormalities, this was seen just because over time, they think that because you're giving this medication directly in through the spinal cord, although it has high specificity for these motor nerves, you also have sensory nerves out there. So over time, they have seen that there could be side effects related to sensory side effects, meaning in the form of numbness in different parts of the body and less frequently pain. That's why there was a lot of significant changes in that regard. Even before getting the medication, then it will not be reliable whether to see if it will come from administering the medication or not. This study met its primary endpoint, provided a good increase on the Hammersmith scores. The changes, these are just essentially numbers, but they were significant, essentially. Although it didn't meet all the secondary endpoints, it showed trends towards benefit. Meaning trends towards benefit means the majority of the times they will see improvement on the revised upper limb score or improvement in the pulmonary function testing. But primarily they based on the efficacy on this one, on the improvements on the Hammersmith score. The side effects, they were pretty much similar between the patients who received and the patients who don't. So then again, nothing new, safe, well tolerated, despite increasing the age up to 18 years of life. And the following study, it is a little more expensive, is a efficacy and safety of the intrathecal Zolgensma in patients with SMA who had discontinued treatments with either nusinersen or risdiplam in the past. It was an open label study, meaning that there was no comparison with similar type of patients. The inclusion criteria were patients between 2 to 18 years of life that should have discontinued these medications after a certain amount of weeks. They just needed a confirmation of 5q SMA with any numbers of SMN2. However, another just consistent thing throughout these studies is that they should have been able to sit independently, but never had the ability to walk independently. The exclusion criteria: elevated titers, abnormalities on liver function or the blood lines, or required invasive ventilation as described on the previous arms of the study. Now, they mentioned that the most commonly reported side effects for this group was transient decrease on the platelets, perhaps a little bit of bloody nose. They were all non-serious. They were all resolved. None of them required hospitalization. There was a few of them that had increased liver enzymes. However, they were very mild to moderate, and with the regular prednisone treatment, they went down. So they didn't need an increase on the prednisone or longer time. They actually just went down with the regular protocol. This is what I was talking about, that they saw that some symptoms of that dorsal root change toxicity in the form of sensory changes, numbness on the feet, sensory changes on the arms, neck, or the scalp. However, those were reversible, and they didn't remain there for the length of the follow-up study. There was no thrombotic microangiopathy, the one that would cause clogging on the vessels on your kidney. There was no new malignancies in the form of cancers, and there was no cardiac adverse reactions reported either. Now, for this study, what it showed is that there was a stability of the scores over time, meaning that it showed that it has good amount of efficacy because it didn't show any decline, as you could see here. And didn't lose any points. You might argue that they could have gained perhaps 1 point, but there was no decrease. And this is for the classic Hammersmith, and this is for the revised upper limb module. Same stuff, perhaps close to 1 point improvement. Stabilization of symptoms, which is important because if you were to see how this curve would have been before treatment, they were on a little bit of a decline at the time. So after medication, after this treatment, it seems to have shown stabilization. Now, in this study, aside from those two, let's say, physical therapy type of assessment, they also included questionnaires towards both the caregivers and the patients as well. And they saw that, well, the patient overall health-related quality of life was reported similar before and after treatment. Caregiver overall health-related quality of life was reported slightly higher after treatment for the caregiver. So perhaps there are improvement in that regard. And that's where we are right now in terms of gene therapy itself. Current clinical trials, current things that are ready to go for FDA and expand the label. But what is, then again, even the next steps of gene therapy? Number one is trying to see next generation, or you might say second generation viral vectors, and they are thought just to make them even more specific towards the nerve. Let's say this one had a chance to go towards the liver, the next viral vector ought to be more precise towards the nerves. Of course, expanded eligibility, and that changed by both, by the intrathecal formulation, which would expand the label for it, but at the same time, if you're able to make it even more specific towards the nerve, then you should be able to expand the label to different ages and different types of SMA as well. Change in delivery methods, then again, intrathecal. They are looking at intracerebroventricular injections, meaning that instead of giving the spinal cord, they give it already to the brain, thought to create less side effects. However, that's very early on. Now, there are different genetic companies out there that are modifying how AAV9 works, and they are trying to make it even less producing of inflammation. So you should be able to also give higher doses, right? They are also trying to see other types of viral vectors for spinal muscular atrophy. This AAV9 has been used, but they are working on an ABVR H10, and there's other type of vectors that have been used also for other type of neuromuscular conditions as well. They're essentially just working on either making it less inflammatory or have more efficacy towards it. There are different studies going on, and this is just a little bit on the, if they just change just a little bit on part of the sequence on these viral vectors, they should be able to see that they will have less expression on the liver, they would have they will remain for longer time within your body. They will have less expression on the heart. They will have more expression on the on peripheral tissue. So just make it just a lot more specific. And as I said, these studies have been going on ever since 2018, but it just takes quite a long time. And of course, they start with mice and they keep going on towards people. How can patients and parents can get involved in what comes next for gene therapy? I always say that clinicaltrials.gov, it is the main source. They have changes over time, so it becomes a little bit more patient friendly, and is a simple search. And that kind of gives you a little bit of the control into, hey, I've been reading these or I have seen these. And then you bring that information towards your specialist, right? I always like to say, and I always encourage patients to, whatever you hear, whatever you see, just ask us at any time. Our job is to respond. Our job is that even if we not have heard at the time, go ahead, read it, and just being able to give you, you know what, that study seems to be going somewhere, or that study doesn't seem to be going anywhere. Just because they are posted on clinicaltrials.gov doesn't mean that they are proving anything good or bad, or they have high chances of success or not. Joining registries and patient advocacy networks, QSMA, MDA, patient registry, it also helps because then you will get alerted whenever there's a new clinical trial that your kid might be eligible to. The advocacy groups, as I mentioned, are pretty up to date as well. They do keep all their websites just very up to date with those things. So it's always, if you doubt the QSMA, MDA, your sources, and then you can cross-check also with your physician. Now, there are certain challenges and ethical considerations for the use of gene therapy in patients with SMA. Sadly, one of them is the high cost, and this is honestly an insurance evil work, let's say, just because they know that if they are very little at the beginning, they will get insurance out of the commercial insurances. But once they get the diagnosis, after a certain time, they can go to Medicare. So they try to delay as much as possible insurance. That's where a lot of the work comes in and a lot of the push comes in for it. And as I mentioned, there's the state of California. I have seen part of their insurance guidelines that they actually ask you to test for the SMN2 positive variant because they have denied patients just because of having that variant. Rather unfair, but because it's such a high cost. And if there's several studies out there that have compared the lifetime cost of gene therapy versus nusinersen versus risdiplam, and you might say that gene therapy, although is the higher cost initially, over time is the least expensive, not only for the medication itself, but for the other treatment-related cost that would be associated with it. Depending on the countries or kind of where you live, even in more rural or underserved areas, it just can get harder to access these therapies. One of the other, perhaps a little bit limiting factors, is that necessity to sometimes relocate just closer as much as possible to a center that could have a good amount of experience to assess for these side effects. So usually rural areas, it just becomes a little more complicated. But then again, it's your team that has to make it happen. It's your team that has to work with your primary care or with your local labs and just ensure that these things are happening. As I said, the insurance are very many issues. There are different hospitals that work on different ways of delivering the medication that can delay it a little bit longer. Those buy-to-bill hospitals, yeah, they tend to be just faster just because their medication is there and you will get it, and the insurance battle just keeps going afterwards. Early intervention is critical, as we had mentioned, for those patients who can get it. Challenges in early diagnosis. Thankfully, here in the United States, as I mentioned, SMA currently is part of the newborn screen. So that one should not be a challenge for longer. Financial barriers, same insurance. Advocacy needs, just so we can try to overcome these roadblocks that insurance companies keep putting on us. And again, insurance. Now the criteria and ethical dilemmas. This is a rather complex one, just because currently there's limitations for age and weight. But as we have seen on the latest inclusion and exclusion criteria out of these trials, we see that they are still are ensuring that these medications should be able to provide good level or some level of improvement, as opposed to no change from the baseline standard of care. And therefore, having true and honest conversations with the families in terms of goals and expectation becomes paramount before making any type of these decisions. If and when these medications become available, of course, there might be, then again, once it's confirmed that it's safe and has good efficacy, there might be high demand. So it's our job as a medical system to try to create different groups in which we can deliver the medication consistently to all the patients who can and who would like to. And that is a little bit of, then again, practice dependent. However, keep in mind that we all are just trying to aim for the same. If this is something good, if this is something safe, we want to be able to give it to everyone who can. Long-term unknowns, of course, currently redosing currently is out of the picture just because we know that once you have created immunity against this ABV9, then the next time you receive similar things, your body will react out of proportion to it. However, when I said currently, just because there is work that is being going on behind the scenes in trying to, what if we decrease the immune system in some way? What if, we use a very different viral vector and so on and so forth? The off-target effects, which is a thing, then again, complicated again, we still not sure, just because we know that the SMN gene and the protein, it is expressed throughout the body, but it has the major effects on the nerves, but it is expressed throughout the body. So do we want it to be expressed in other tissues? Do we not want it to be expressed in other tissues? Or how much is good and or bad expression? So far, what we know is that we need it to express on the nerves. And as long as it's expressed on the nerves, there will be benefit out of it. Currently, there is no reports of creating malignancy within your body, right? Because you are, at the end of the day, giving a substance that had not been in your body, and although it doesn't assimilate initially in your DNA, the theory is that it shouldn't assimilate, but we're still within 10 years of these studies. So more time will keep us telling us that for that specific questions. However, currently there's no indication that it should assimilate in your body, that it should go rampant in your body, that should create any issues like that. But it is important to also be aware of that it's been 10 years, so there could be more information to come. And as a community, as I mentioned, we should initiate this discussion. What is the true goal? What is the expectation? Is it to be able to stay awake for longer in the day, able to read more, able to play video games, to use better verbal or non-verbal communication, or regain motor function? So having an honest and a realistic goal is very important. The quality of life, it is very independent from patient to patient. As we saw in the last study, it showed that for the patients, the quality of life questionnaire was about the same before and after therapy. However, if you go through the different items that the patients have felt that there was improvement, let's say there was at least 50% improvement in the majority of the mentioned things, meaning control of this area of the body, or greater strength, or greater energy. So there's somewhat of a disconnect sometimes what quality of life and the perceived improvement it is. So that's something that the patients themselves, yourselves, would tell us more, So once they tell us, what, I want to do this or want to do that, we should be able to tell you, hey, let me see out of the experience, out of the numbers, out of the things that we can read upon. You could expect that or perhaps not, but having an open communication, I think, is the most important part. These are some of my slides and my references, and that's all I got. I am open for questions.
Great. Thank you so much, Dr. Lopez-Chacon, for being here and sharing your time and expertise with us. We will now do a Q&A session. So if anyone has any questions that they'd like to ask, feel free to put it in the chat box. But for now, I will go over some questions that were submitted upon registration. So the first question I have is, when will gene therapy be available for older patients? Please talk about safety as well. Thanks.
Yeah, so should be soon enough. They already had some of the main data out of these studies. So one would foresee within the next year, we'll find out. I want to say that it's most likely going to be available for older patients. In terms of the safety profile, you still require to take your steroids the day before starting therapy, continue it for the first month, decrease it over the second month, and keep monitoring for the third month. But aside from some elevation on liver enzymes, the side effects, at least seemingly compared to the intravenous version, seems to be just a little bit better safety profile. Definitely no serious side effects. None of them require hospitalization. all those numbers went back to normal. So it seems to be overall safe in that case.
Great, thank you. Next question, also about adults. Are there any specific trials focusing on SMA3 in adults, or is it more an overarching genetic targeting trials?
So for SMA type 3, there had been historically different trials aiming for different things aside from gene therapy. There's nothing very new. There is trial of gene therapy, a product from a company in China, and the only location is in China. Um, but I would say that it might be rather extrapolated from the gene therapy, proven that it is then again safe enough that taking into consideration that it is very safe and you should be able to change your baseline disease modifying therapy towards something safe that doesn't produce side effects and provides the same amount of benefit. I think, yeah, it might be a continuation of these gene therapy trials.